Hi, Raj.
Hi, Rahul. How are you?
I'm good, Raj. Thank you for being here. It's
Yeah,
great,
of
great.
course.
We keep on seeing you on Twitter. It's so exciting.
Of course. Yeah, no, thanks for for your time and on a Friday evening. So yeah, I really really appreciate it. Yeah, looking forward to it, of course.
Yeah, so Dr. Nikhil actually tends to see one myeloma a day. But India being India, and there are like thousands of touch points in a day where you can actually not get away from anything, right? From the house to the professional to personal life. There's such
Yeah.
so many touch points. But yeah, there's a lot of load of multiple myeloma, which Dr. Nikhil is currently seeing.
Okay.
And at the same time, we are looking for uh, bringing out some really nice papers where we can see Dr. Nikhil has seen that Dara VRD transplant actually doubles your cost and see what we can
Yeah,
do.
people, there's a lot of young myeloma patients.
Already 7 o'clock. Dr. Nikhil, are you there?
Talk and then 45 minutes discussion. So that's good. Yeah, we can, there's a lot of things to discuss in maintenance. It would be fun. Yeah, I'll keep my talk probably around 40 minutes. I should be able to end in
Yeah, yeah.
40.
Can stop it or not? Do we have the markers now to see whether we can do that? A brief touch upon the mass
Yes.
spectrometer, based MRDs, uh, what is the best strategy, how to actually monitor for the chip origin on lenalidomide.
Yeah.
So yeah, so people are pretty excited about knowing what is happening.
Yes.
Dr. Nikhil, are you there? Yeah, so we can start now.
Thank you for accepting our invitation on such short notice
No,
and
that's
joining in.
Recording in progress.
Okay, so we are live. I welcome Dr. Raj Chakravarti, who has made his name in such a short time in the world of myeloma. We are all getting enlightened by his very crystal clear thoughts on amyloidosis, about what next to be done, what is the maintenance strategies for amyloidosis. He's wrote a very provocative article whether I really need a transplant in amyloidosis or not, leaving many more questions to be explored through collaborative efforts across the world, Middle East and Africa. So people across the countries tends to gather on a Friday evening to listen to this exciting talks. Without wasting much of our time, I will hand over to Dr. Nikhil. A brief introduction he will give about the department, which is like comprising of 15 doctors and the access to all the latest genetic screening and paraphernalia which are there under one roof with Dr. Srinidhi. Over to Dr. Nikhil.
Thank you, Dr. Bhargav. I welcome one and all to this Innovations in Hematology webinar series. Today is a very special session. We have completed 1 year of this webinar series, where we have monthly webinars covering challenging clinical scenarios, where an international expert in the particular subject domain gives a brief lecture, followed by a question and answer session, where we get questions from across the country, from hematologists as well as oncologists, for discussion with the subject expert. Over the last 1 year, we have been fortunate to have stalwarts of hematology, ranging from various topics in benign and malignant hematology. And we hope we have been able to address clinical scenarios and challenging situations for which a diagnostic dilemma exists. And we have been able to enhance our clinical practice in collaboration with these stalwarts of hematology. So this webinar series is by the Fortis Institute of Blood Disorders, which under the umbrella of this institute, we have adult and pediatric hematology units. What makes us unique is other than 10 hematologists, we also have a dedicated infection disease specialist, a critical care anesthetist, a molecular hematologist, geriatrician, and nursing staff, a hematology trained nutritionist, and physiotherapist who was integral part of this department. So today, we would be discussing about the maintenance strategies in multiple myeloma. With the advent of novel treatments as well as existing monoclonal antibodies like daratumumab, this has gained a lot of traction. Should we give a single drug maintenance? Should we give a double drug maintenance? Is there any role of daratumumab in maintenance? And in the era of immunotherapies, how do maintenance strategies to enhance the progression-free survival in myeloma patients while not affecting their quality of life adversely? So this is our approach at Fortis Institute of Blood Disorders, where for all transplant eligible patients, we give 4 cycles of DARA VRD followed by a transplant. They are put on a maintenance after disease reassessment at day 100. And for transplant ineligible patients, we usually give 6 to 8 cycles of a triplet, which includes daratumumab, followed by a maintenance. It has been our approach to look at MRD negativity as a surrogate for deep disease control before considering maintenance. Today, we would love to discuss with Dr. Raj how MRD pans out in deciding on which patient should get a daratumumab maintenance based on recent trial data. Otherwise, our practice is to give a lenalidomide maintenance in standard risk myeloma patients and bortezomib with len maintenance in high-risk patients as per the standard guidelines. It's my pleasure to introduce our guest speaker for the day, Dr. Rajshekar Chakrabarti. who is an assistant professor of medicine in the Division of Hemato-Oncology at Columbia University, Irving Medical Center, New York. Dr. Rajshekhar, after his receiving his medical degree from the University of Delhi, he completed his residency in internal medicine at Mount Sinai and subsequently spent 3 years as a clinical researcher in the prestigious Mayo Clinic in plasma cell disorders. During his fellowship, he has conducted outcome research with a focus on quality of life and treatment-related toxicities, which is one of the key issues that we would be discussing today in patients on maintenance therapies. And currently, he's working as an assistant professor, specializing in myeloma and amyloidosis program at the Columbia University. His clinical research focuses on the care of patients with various plasma cell disorders, and he's actively involved in clinical trials and research in this space. He has extensively published peer-reviewed journals in both national and international journals of repute. And we welcome Dr. Rajshekhar Chakrabarty to discuss about the maintenance strategies in myeloma. Before I hand over the podium to him, I would like to introduce the speaker for our next webinar, which will be on the 9th of May at 7 p.m., where Dr. Uday Popat from MD Anderson would be speaking to us regarding therapeutic strategies to prevent relapse in AML in a post-transplant setting. This is our team at Fortis Institute of Blood Disorders, where we have Comprehensive Center of Excellence for Myeloma and Amyloidosis. I hand over to Dr. Rajshekhar for today's lecture. I'll just sharing my screen.
So, let me share my screen. Just a second. I'll just put it on a slideshow. Okay. You can see the screen, right?
Yeah, perfect. Your screen is visible and you're audible.
Okay, so thank you, Dr. Nikhil, for the invitation. I'm really looking forward to this session today and to talk about post-transplant maintenance therapy in multiple myeloma. I decided to focus mostly on post-transplant maintenance therapy because, as you know, for the non-transplant patients, the treatment is slightly different. So we will focus mostly on the data that we have for the post-transplant patients today. And I have around 35 slides, so I'm hoping to be done by about 40 minutes, and then we can really have the discussion after that, which is, I also intend to learn a lot from your experience as well, and it would be hopefully a very fun discussion. So I'll go ahead and start. These are my disclosures. So before we jump the data, and thanks, Dr. Nikhil, for sharing your current paradigm. Currently, at your center. And just remind me, for transplant eligible patients, you are using, for the most part, DARA VRD induction, correct? If the patient can afford it, quadruplet induction. Is that correct?
Yeah, that's right. It's a standard practice to use DARA VRD quadruplet for all transplant eligible patients, provided they are affordable for DARA.
Okay. And if they're not able to afford DARA, then you use VRD, right?
Yes. Then we use the triplet VRD.
Okay. So all of you know this, I don't need to repeat this, but the standard paradigm for myeloma therapy today is basically, let me remove this a little bit. Patients get induction therapy, then consolidation therapy, and then maintenance. And for transplant-eligible patients, that consolidation is a high-dose melphalan followed by autotransplant. And for transplant-ineligible patients, they just get an extended induction therapy for about 8 or 9 cycles, and then they go on to maintenance directly. I put an asterisk around transplant because, especially in the US, given the data that have come out in the past few years from the IFM and the determination trial, that delayed transplant does not really worsen overall survival, at least with the follow-up that we have right now. Although the PFS, is definitely superior with upfront transplant, but the overall survival seems to be similar thus far with upfront or delayed transplant. In the US, many patients are opting these days for deferred transplant at first relapse, especially patients who are not high risk. But I know that in India and many other countries, even in Europe, for example, upfront transplant remains the standard, which is is very reasonable given the strong progression-free survival benefit, and maybe even an overall survival benefit if there is lack of access to subsequent downstream treatments like CAR T cell therapy or bispecific antibodies, for example. But for the most part, the paradigm remains induction with 4 to 6 cycles. Typically, DARA VRD is what we are using at our center also. And then patients get a MEL 200 auto transplant, and then they go on to maintenance. So today's talk will be focused on maintenance. Go to the next slide. Just a second. My computer is froze. Like, for some reason, I cannot. Hmm. For some reason, I'm not able to go to the next slide. I don't know why. Just a second. Let me. Here, right? So I usually do it from my keyboard in my laptop, but let me stop share for a second and then let's see what's going on. Okay. Okay, now I'll share again. Uh, if I increase the size of this, is that for some reason when I'm going to the presentation mode, it's getting frozen. Can you all see this, or is it too small for you, the fonts here? One more time. Okay, yeah, let's see. Current slide. Okay. Okay, now it's working. All right. So we will start with a case. A patient that I saw a couple of years ago in clinic. So 64-year-old female with a history of hypertension, hyperlipidemia, and diabetes, who was referred to us for IgG lambda multiple myeloma. She had a typical presentation with diffuse rib pain, back pain, pain in her left flank, and PET scan showed multiple FDG avid lytic lesions in her ribs as well as in the thoracic and lumbar spine. Thankfully, the renal function was normal. Bone marrow biopsy showed about 70% plasma cells, and FISH showed hyperdiploidy and gain 1Q. So she had gain 1Q as the only high risk abnormality. And she had RISS stage 2 based on the albumin and the beta 2 microglobulin and cytogenetics. So she received induction treatment with DARA VRD for 6 cycles, followed by a MEL 200 auto transplant. She now comes to our clinic at around day 100 post transplant. Her day 100 bone marrow biopsy was MRD negative. We have Euroflow that we have in house, and the patient was MRD negative at 10 power minus 6 sensitivity. Also was MRD negative on adaptive clonoSEQ, which we also do as standard of care. And then the PET CT was negative for any FDG avid lesions, and also had obviously a negative serum and urine immunofixation with a normal serum free light chain ratio. So basically, the patient was in an MRD negative stringent CR at day 100 post transplant. And the question is that what maintenance would you use at this point? She's asking, first of all, does she even need any maintenance? And if so, then what maintenance? So I think I'll start with a provocative question here, that does this patient even need any maintenance treatment, given the patient has gotten a really good induction treatment, transplant, and now is MRD negative at 10 power minus 6, with negative PET scan. And we know that these patients tend to do really well. And if yes, if the patient needs maintenance, what would be the most optimal maintenance therapy for this patient? And here I put in the options, all of the choices for which we have randomized controlled trials. Not all of them are practice changing, of course, but for all of them, we have a randomized controlled trial now. For some, actually, even more than one randomized controlled trial supporting data on that. And it's becoming a challenge to pick the optimal treatment for each patient. And that's what we will, do in today's talk. And hopefully we will see, we will be able to get a nuanced look on the data. So I would mention one thing though, that although there is no one right answer here, there are definitely one or two wrong answers. And we'll go, once we go over the data, we will see which are those, which we should definitely not be using. But there are a few which would be considered reasonable with the current data that we have. So first of all, what is the goal of maintenance therapy? And I think before going into the data, again, it's important to take a philosophical look at what are we trying to achieve with maintenance treatment, and also understand that patients, when they come to us for maintenance treatment, their situation is different compared to when a patient is coming to us with newly diagnosed myeloma, when they are having significant bone pain or having, renal insufficiency. They're about to go on dialysis if they are left untreated. And at that point, the risk benefit calculus is much different compared to maintenance treatment when a patient is coming to us post transplant and they are otherwise, by around day 100, they are recovered from transplant. They do not have any disease related symptoms. They're eager to get back to their life. If they have a job, they're eager to get back to a job, and they don't want a treatment to be taking, years and years that would significantly impact their quality of life, that would not allow them to do a job. So the goal of maintenance therapy is basically to delay disease progression and improve overall survival. And that's very, very important. We really want a maintenance treatment to alter the natural history of disease. A mere PFS benefit without any impact in overall survival is generally not considered enough for maintenance treatment. The bar is usually much higher for maintenance. And especially if that small PFS benefit is associated with significant toxicity, that even makes it, that makes it even more difficult to accept a maintenance treatment. And of course, the maintenance treatment should maintain the quality of life. It would be unreasonable to expect a maintenance treatment to improve quality of life, given that, at the start of the maintenance, most patients are usually fairly asymptomatic, but at least it should not worsen their quality of life. It should not have substantial symptomatic toxicities, which it should not lead to significant time toxicity, like patients spending, hours in infusion center every week. That is unacceptable in maintenance treatment. So these are, broadly the goals of maintenance treatment. And I think we need to keep this big picture in mind when we look at the data, because sometimes we tend to get too swayed by just the Kaplan-Meier curve and the numbers, but the big picture is very, very important to understand why some treatments are good fit for maintenance therapy and some aren't. So this is a brief history of maintenance treatment. Maintenance is nothing new. It has been tried in myeloma since 1990s, and in the olden days, for example, in Canada, there was a large cooperative group study that was done with thalidomide, which is rarely used these days, but thalidomide with prednisone versus prednisone was a randomized control trial. And it was a positive trial with significant PFS benefit, but there was no overall survival benefit, and it led to a worse quality of life. And hence, despite being a positive trial for PFS, this trial was not adopted in routine clinical practice, and we never used thalidomide maintenance, despite this trial that was positive for PFS. Similarly, there was another trial, there were actually several trials on interferon, and in like early 2000s, there was a large meta-analysis that was done combining the data from all those trials, from 30 randomized trials. Many of them were very small, and actually there was, in the meta-analysis, there was a 4.4-month PFS benefit and a 7-month overall survival benefit with interferon. But despite that, interferon was rarely adopted in clinical practice because of its side effects, and the patients have to come in to the infusion center. It's not an oral drug, so with all of that, it was never really adopted in clinical practice. So you can see here, that the bar for maintenance is much different than the bar for treatment for newly diagnosed or relapsed multiple myeloma. However, things changed with lenalidomide. That was the first drug where, it opened the door for intervention. It opened the door for maintenance treatment, given it was oral. And although it does have some side effects, but it was considered acceptable and still is for patients, during the maintenance setting with appropriate supportive care and dose reductions. So this is a landmark clinical trial, the CALGB 100104 trial that was done in the US. And this was the trial which I would say was kind of a seminal trial that led to the introduction of lenalidomide in the maintenance paradigm. In this trial, patients could get any induction treatment. It was not really assigned per protocol, then transplant. And after transplant, at that point, patients enrolled in the trial where they were randomized to placebo or lenalidomide. And this trial was, clearly positive, with, you can see, a strong progression-free survival benefit with early separation of the Kaplan-Meier curve, and also an overall survival benefit. And this was the first readout of the trial. With subsequent readout, the overall survival benefit was even stronger. Subsequently, there was a large meta-analysis that was done with 4 randomized controlled trials of lenalidomide And basically, in the meta-analysis, the progression-free survival was even more profound. You can see there was a median PFS of exceeding 4 years, which was really stellar at that time with len versus about 2 years with placebo or observation. So just with this data, even without an overall survival benefit, just with the PFS data, you are having more than 2 years of PFS benefit with an oral drug. So it was really impressive, and that did translate into an overall survival benefit. But you can see that the curves don't really separate, until about 5 or 6 years. So that also tells you, important the importance of long-term follow-up. And I think we have seen that in many other situations as well, including a transplant trial, the EMN02 trial, where the overall survival curves did not start splitting until 5 or 6 years. And here you can see the 7-year overall survival was 62% with len maintenance and was 50% with placebo or observation. So based on this data, I think it really cemented lenalidomide as the standard maintenance treatment. And until I would say even now, we are using lenalidomide as standard maintenance treatment for pretty much all patients with myeloma. But the first time that I really questioned the data that should this data still apply to our patients was once in ASH, I think a few years ago, I heard a comment from Dr. Luciano Costa, who is the PI of the master trial, which we'll go over in a few slides. And he made a very astute point that lenalidomide maintenance was built on the backbone of doublets. It was not built on the backbone of triplets and quadruplets. And that really, challenged me to think that whether this is an evidence that has already expired. And we don't know that, of course, yet, but that's definitely thought-provoking. So before we go on to that, I also wanted to put out a safety signal here that len maintenance also leads to increased risk of SPM or second primary malignancy. And, that risk is small, but definitely, especially when we are giving lenalidomide to long-term to patients, and with so many patients, every patient with myeloma receiving len, we do see these cases of MDS, AML, and even some ALL cases have been reported with lenalidomide, and also solid tumors. So now the question is that, sorry, again, it's not going to the here. Trying to minimize this. Okay. So the question is that what was the induction therapy and the level of response in these trials? So as I mentioned, that len maintenance was built on the backbone of doublets and on the backbone of older regimens. So when you take a close look at some of these trials, the CALGB trial, only 41% of patients had received bortezomib in induction treatment. Only 35% of patients had received len in induction treatment. So you have more than half of the patients in this trial who are seeing lenalidomide the first time in maintenance. So of course, if the control arm is never seeing len and the intervention arm is seeing len for many years in maintenance, they're of course going to have a better PFS and overall survival because len is an effective drug. But does that really apply to the patients that we are treating today with Dara-VRd induction treatment? Similarly, in the IFM trial, you can see that 46% of the patients got Velcade Dex, a doublet induction treatment, and the remaining, about 50% of patients got vincristine, doxorubicin, and dexamethasone, which we never use these days, and none got len in induction treatment. So basically, it tells us that these patients, the lenalidomide maintenance was established mostly on the backbone of doublets and ancient induction regimens such as VAD, not on the backbone of modern induction regimens. And I think that's a very, very important thing to remember. And we will see some of the trials that we have, that have tested that. So what has changed in the landscape of the multiple myeloma treatment? So if we go back to the len maintenance trials. So, this slide, Dr. Moyuddin from University of Utah had this really astute slide, which I've adopted and modified a little bit. So when we look at any trial of maintenance treatment, we can't really focus only on maintenance because that is not only what determines the outcome. We have to also look at what patients got before maintenance. So what was the pre-maintenance treatments, because that can impact what the PFS will be with maintenance. And we have to also look at post-protocol or post-maintenance treatments because that can definitely impact overall survival. So in the len era, most of the pre-maintenance treatments were not really good treatments, right? So they were either doublet, VD, RD, or some even older treatments like VAD with vincristine. And post-lenalidomide also at that time, daratumumab was approved in the US only in 2015, and these trials were done in, around 2010 to 2012. So many patients could not even receive daratumumab before dying, unfortunately. And of course, bispecific antibodies and CAR T cell therapies were not available during that time, right? So, what has changed now? So sometimes, now the main things that have changed is in pre-maintenance patients are receiving at least a triplet in most countries, if not a four-drug treatment. At least they are receiving VRD or KRD. And post-maintenance, as you all know, we have so many options now, including teclistamab, elranatamab, and CAR T, and of course, like Kyprolis-based regimens and so many other options. So things have significantly changed in the myeloma landscape, and I worry that the len maintenance data may not be applicable in the current era. So we'll next focus on the Cassiopeia trial. So Cassiopeia trial assessed the maintenance after quad induction. So, this is, I think, a very, very important trial, given it gave us how maintenance will look like when the induction is really optimal as per the current standard. So here in this trial, they had two randomizations. The first randomization was an induction question. So patients randomized to DARA VTD versus VTD. And the second randomization was a maintenance question. That is, patients randomized to DARA maintenance versus observation. Now, it's important to note here that the control arm was not len, which would have been ideal. We would really have wanted to know how DARA compares against len. But, it was, I would say, with observation as the control arm, we got to take a really clean look at the impact of DARA maintenance when you have, daratumumab and a quadruplet in induction treatment. So this trial, if you look at the left, is the progression-free survival overall. And of course, DARA maintenance won, compared to observation. There was a significant PFS benefit of DARA maintenance over observation. Till date, that has not translated into an overall survival benefit, but it might as well, with long follow-up, given that the separation in the PFS curves is quite robust. But on the right side, what they did was they looked at the interaction by the induction arm. And as you can see here, that the bulk of the benefit from DARA maintenance was achieved by patients who basically got VTD induction treatment. So patients who got VTD induction treatment and DARA maintenance is the green curve, and patients who got VTD induction treatment and no maintenance is the red curve. So there's a big difference. On the other hand, if you look at the DARA VTD arm, so in patients who got DARA VTD, in those two, you can hardly see any difference between the curves. So with long-term follow-up, the curves did separate a little bit. There is a small difference between DARA VTD plus DARA maintenance versus DARA VTD plus observation. But I would go on to say that the difference, although it may be barely statistically significant, is not clinically meaningful. And again, if we go back to the first slide, that we don't give maintenance for a mere, like a small PFS benefit, right? We give either for a clinically meaningful PFS benefit, or definitely an overall survival benefit. And all the data is overall very, very well tolerated, other than the cost, of course. It does not have any major symptomatic side effects. But in my mind, at least when I look at these curves, the clinical benefit in the DARA VTD induction arm is not clinically meaningful. And you can even see that the upper bound of the confidence interval, it touches 1 here. So as I said, the bulk of benefit from DARA maintenance was derived from patients who did not receive DARA VTD induction, and there was a modest and I would go on to say clinically insignificant benefit in patients who received DARA VTD. Then we have the Perseus trial, which is more contemporary, where patients got DARA VRD induction, and then patients got in the DARA arm, they basically went on to receive DARA R maintenance, and the VRD arm, they went on to receive R maintenance. Now, an important point I would note here, that there was no second randomization here at the maintenance, and that's very, very critical. To isolate the impact of maintenance, you really need a second randomization. An example of that, if you guys remember in the leukemia, there was this ratified trial of midostaurin, where patients got the FLT3 positive AML patients got induction treatment with midostaurin versus induction treatment with placebo, and then some patients got transplant. But the midostaurin was also continued in the maintenance in the experimental arm, whereas the control arm obviously did not get a midostaurin maintenance. But even in that trial, there was no second randomization for midostaurin at the start of maintenance. And because of that, the FDA did not really give an approval to midostaurin for the maintenance. they only give an approval for induction. It's very, very important because to isolate, many companies will design trials like this to kind of sneak in an experimental drug in the maintenance setting. But the FDA is very clear on that to really demonstrate benefit in maintenance, we have to do a second randomization at the start of maintenance. We can't just do a first randomization and assume that the benefit is from the maintenance, because we don't know whether the benefit is coming from induction or from maintenance. So, of course, the Perseus was a positive trial. Here you have a significant PFS benefit with VRD over VRD, but we don't know whether that benefit is coming only from induction, whether the benefit is coming, from induction plus maintenance. It cannot be only from maintenance because the curve starts separating very, very early during the induction. So it can either be only from induction or from induction plus maintenance, and we don't know the answer to that. Then we had the Auriga trial, which was DARA-R versus R maintenance. But another catch here in this trial is that anti-CD38 monoclonal antibody was not allowed in induction. So again, it does not answer the question, whether this trial will hold in patients who get DARA-VRD induction. But, I'll show you what induction patients got, but they were not allowed to receive DARA in the induction. And the patients basically had to be MRD positive at post-transplant. So they selected the patients who were more likely to benefit from DARA, which is fine. We really need these kind of risk-adapted trials more and more, because I don't think one size fits all is a good strategy anymore, given the heterogeneity of patients' responses to different treatments. And then they got DARA-R versus R, and DARA was continued for a maximum of about 3 years. Now, what induction treatments the patients received? So about 70% of patients received VRD induction, which I would say is reasonable. It's a reasonable standard of care. Still, a lot of patients, are receiving VRD induction, especially in low middle income countries. And even, in some community practices in the US, we do see VRD induction being used. Then the remaining about 11 to 16% receiving VCD induction, and some receiving KRD induction. And the top line results, the MRD was the primary endpoint in this trial. You can clearly see that DARA-R significantly improved MRD over R, and which was not surprising. Of course, in the control arm has never seen DARA, and the experimental arm is seeing DARA, and we know that DARA is an effective drug, so it ought to improve the MRD negativity rate. It did also translate into significant PFS benefit. You can see there is an early separation of the curve, and there is a significant PFS benefit. So this trial, I think, definitively proves that if you receive VRD induction, a non-DARA, a triplet induction, then adding DARA and maintenance definitely leads to a significantly, I would say, clinically meaningful PFS benefit. There was no overall survival benefit, but maybe there is a slight trend that's emerging. I think we really need long follow-up. There were very few events here, so hard to say anything about the overall survival. But I won't be surprised if this PFS benefit translates into an OS benefit with long-term follow-up. So, basically, this trial taught us that DARA-R greater than R for MRD negativity and PFS when an anti-CD38 monoclonal antibody is not used in the induction therapy and patients are MRD positive post-transplant. We don't know if this results would hold if they took all comers, including patients who are MRD negative post-transplant. We don't know if DARA would really be beneficial in that setting. Now, this is a trial that I'm really excited about, and it's not ready yet, the second randomization part. And this will really answer the question whether adding DARA improves, PFS or overall survival in patients who got an anti-CD38 based induction treatment. So this is the GMMG's German trial being run by the Heidelberg group, where patients are randomized to a quad versus triplet. So isatuximab VRD versus VRD. And this is the first part of the trial. And then after that, they undergo transplant. And then there is a second randomization to ISA-R versus R, ISA-LEN versus LEN. And that second randomization will really give us the crucial answer. The first part has already been reported. And as expected, quadruplet was better than triplet in terms of MRD negativity and progression-free survival. Then also the SWOG S1803 dramatic study will also give us an answer of whether DARA plus LEN versus LEN. DARA plus LEN is superior to LEN alone. And it's a very, very large trial with 1,100 patients, which is almost completely accrued. And this trial allowed patients with DARA VRD induction. So we are hoping that this trial will have roughly half of the patients who got DARA VRD or DARA KRD induction. And we will be able to look at whether DARA plus LEN improves PFS in those patients who got either DARA VRD or DARA KRD induction. So, given we have discussed a lot of data, I just wanted to quick recap thus far before I go further into some of the other trials. So, so what we have learned from all of these, all of these trials. So first is, Len maintenance has demonstrated OS benefit in the era of doublet and alkylating agent-based induction therapy. And I think it's very important to remember that. Nevertheless, it is the standard of care currently. We are still using it. Overall, I would say it's reasonably well tolerated. Now, does Len maintenance provide benefit in the era of quad or even triplet like VRD or KRD induction? We don't know. There has been none of the randomized trials of Len maintenance have used quads or triplets as induction treatment. Does DARA maintenance provide benefit in the context of a triplet induction, which was VTD? I think we can reasonably extrapolate the data to VRD as well. So the answer is yes, there is a large PFS benefit, which I won't be surprised if it translates into an overall survival benefit as well in patients who got triplet induction. But does DARA maintenance provide benefit in the context of a quad induction? I think the benefit is extremely modest. In my opinion, it's not enough to change practice. Then I think the bigger question here is DARA Revlimid better than Revlimid in the context of triplet induction? I think the answer is yes. If MRD positive post-transplant, Origa showed that if patients are MRD positive post-transplant, then absolutely DARA R provides better MRD negativity and PFS compared to R. We don't have overall survival data yet on that. And is DARA R greater than R in the context of quad induction? I think we absolutely don't know. And I think here I would caution you that based on the Perseus trial, there was some secondary analysis of the Perseus trial that was presented at last EHA, where they showed that the MRD conversion from positive to negative was higher in the DARA R arm compared to the R arm. And based on that, many people extrapolated that DARA maintenance is superior to R in the context of quad induction. But I don't think we can make that jump because patients who were in the quadruplet arm, they got a better induction. So it's possible that at the start of maintenance, they had a lower MRD burden. Even though they were MRD positive, they had a lower MRD burden. And that's why it may have been easier to flip them from positive to negative compared to those who got triplet induction. So I think until we get the results of the GMGHD7 and SWOG dramatic trial, we don't know whether DARA R is greater than R in the context of quad induction. Now I will switch gears a little bit into PI plus lenalidomide induction as maintenance treatment for high-risk patients, because this often with the high-risk patients, especially those who are double-hit patients, those are the patients that we really struggle with because they do poorly no matter what we do. So I think the Forte trial was a very well-designed trial where, again, patients got triplet induction, either KRD or KCD, and then there was the first randomization to transplant, and then after that, there was a second randomization to KR versus R. And again, the second randomization again here is crucial, to isolate the impact of whether adding a proteasome inhibitor to lenalidomide improves PFS compared to len alone. And overall, it was a positive trial, but you can see here that the benefit was more, I would say, in the high risk patients compared to the standard risk. In standard risk patients, they did fairly well, regardless. The p-value did not meet the statistical significance. In the high-risk patients, there was, although they continue to relapse, obviously, but there was statistically significant PFS benefit with KR versus R. I think with double hit, the sample size is too low, so it's hard to make any conclusion. There definitely numerically KR was better than R. So this trial showed that yes, adding carfilzomib, does improve PFS across risk status, but more in high risk. The question is that will this translate into overall survival benefit? And we don't know that yet. They have not really published any long-term follow-up data from this to show whether, at least in the high-risk patients, whether this PFS benefit is translating into an overall survival benefit. But nevertheless, it did have a significant PFS benefit in high-risk patients. Now, when I gave the first case scenario, I said that there is not one right answer, but there are clearly one or two wrong answers. So to answer that, so it's important to remember that never use ixazomib plus len as maintenance treatment. This was the Spanish trial, the GEM 2014 main trial, where patients got VRD induction, then got MEL 200 auto, then got VRD consolidation, and then they were randomized to ixazomib lendex versus lendex. And you can see the Kaplan marker for PFS are completely superimposed on each other. So it was clearly a negative trial. And on top of that, the grade 3-4 GI toxicities was 15% in the ixazomib lendex versus just 2% with single agent len. So it was very, very high. If you combine the grade 1 to 4 GI toxicities, the number was very high. I don't think they have published this data yet. This was an abstract at ASH in 2021. We really need to see the data as to how bad the toxicity was, but it was, it was clearly a negative trial. And ixazomib is such an expensive drug despite such poor activity that we should definitely never be using ixazomib in maintenance treatment. Now, I think we'll go to a little bit more provocative question that can we get away without maintenance therapy completely in the era of highly effective frontline therapies? And I think this is a question that's currently a lot of people are asking in the field of myeloma. And we really need to answer it for our patients, given we are subjecting them to such intense frontline treatment and then transplant, and we really need to give them a break, and how long do we continue the treatment, and which causes such a physical and financial toxicity. So we'll go over briefly into the Master-2 trial, which is, really, I think it's a bold trial that omitted maintenance treatment. So a lot of you already probably know the design of Master-2 trial, but I'll briefly recap. So patients got DARA-KRD induction for 4 cycles. Then they got auto transplant, and then they got consolidation 1, which was DARA-KRD for 4 cycles again, and then consolidation 2, which was DARA-KRD for 4 cycles again. And at every place where you see a star, there was an MRD testing done. And if patients were MRD negative at 10 power minus 5, at 2 consecutive time points, they could come off treatment. So you can see that the earliest patients could come off treatment was post-transplant. So imagine how lucky a patient would be if they just got DARA-KRD for 4 cycles and auto transplant, and that's it. And then after that, they are just being monitored without any treatment. And with this strategy, about 71% of patients, were able to put off all treatment, and they entered into an active surveillance without any treatment. There was no maintenance. Only patients who were MRD positive at the last time point, which was roughly about 25 to 30% of patients, at that point they went on to receive single agent len maintenance, which would be the standard of care. Now, I'll not focus so much on the MRD data, but I'll focus more on the PFS data to show you in the next slide here that, in patients who were standard risk, who had no high-risk cytogenetic abnormalities, at a median follow-up of roughly about 4 years, they had an excellent PFS. The 3-year PFS was 88% in these patients with standard risk disease without any maintenance treatment, which again goes on to show that, does len maintenance, is it really providing any benefit to these patients who get caught treatment or MRD negative or standard risk or low risk patients? Whereas patients who had 2 or more high-risk abnormalities, they were around 25 patients in this trial, they did poorly. They had about a 3-year PFS of 60%, which is still better than the historical standards, but, overall, about 50% of them progressed at the current follow-up after stopping maintenance. So I think we really learned from this trial that for patients who are standard risk, who have low risk disease or MRD, who achieve MRD negativity early on, we can probably de-escalate treatment in these patients. And thankfully, there is a trial currently being designed in SWAP to answer that question. Now, if you look at this curve, a lot of I think a lot of key opinion leaders in myeloma, they made the conclusion based on this trial that only if we had continued the same treatment, the DARA-KR or KR maintenance indefinitely, then the double hit curve, the green curve here, would not have been that bad. It would have been much better, and patients who had double hit myeloma would not have relapsed like this, and we may have harmed patients with double hit myeloma by stopping treatment like that. But Dr. Costa and colleagues, did really, and I would say, an astute analysis where they compared Master-2 trial and Griffin trial. So what they did here on the left, is the Master-2, and the right is the Griffin. So Griffin is similar to Perseus trial, where patients got DARA-VRD, then transplant, and then DARA-R maintenance. So remember, there is no PI, no proteasome inhibitor in the maintenance setting here, which ideally we do in double hit patients. But nevertheless, they got DARA-R maintenance. And you can see the relapse curve, the PFS curve for double hit patients are almost superimposable. So by continuing the same treatment indefinitely, albeit without a proteasome inhibitor in the Griffin trial, they did not really have, significantly better outcome in double hit patients. They still did poorly. About 50% of those patients still progressed at a median follow-up of about 3 to 4 years. So, based on this analysis, I think it does go on to show that in these double hit patients, just by doing the same old, the DARA, Revlimid, and the PI, we may not be able to really alter the natural history of the disease. We really need newer treatments in these patients, like possibly immunotherapy. And up until then, I totally agree your approach of using Velcade plus lenalidomide. We sometimes use Kyprolis plus lenalidomide in these patients, but we don't really know whether these patients, what is the optimal treatment for these patients yet. This is another trial by Ben Derman from University of Chicago, where also, it was not a randomized trial, again, a single arm trial, where he took patients who could get any induction treatment and at least 1 year of Len maintenance. And at that point, if they were MRD negative at 10 power minus 6 and PET CT negative, they could enter into this trial of, they call it MRD to stop. So they would stop all treatment and just enter into active surveillance. And with that approach, you can see the 3 year, the 30-month PFS in these patients was really good. Overall, the blue curve. So it's about 85 to 90%, the 30-month PFS without any treatment. So this was, again, all comers. We don't know how that would, this is a small trial, so I don't think it's powered enough to do separate analysis by standard risk versus high risk. But overall, patients who achieve MRD negativity after 1 year, or even after 1 year of Len maintenance treatment, regardless of what they had gotten before, they have really good outcomes down the line. So, I'll go over my interpretation of the data, of maintenance data in the context of DARA-VRD induction followed by ASCT, which I'm glad to see that that's also your standard of care. So it will, it will fit with what the current standard of care is. So if patient is standard risk, does not have any high risk abnormality, and they're MRD negative after transplant, I still do single agent lenalidomide, but I have a low threshold in these patients to aggressively dose reduce or even drop maintenance completely if they have side effects or financial toxicity. So as I said, there is a swap trial currently being designed to answer this question, where they will be taking patients who do not have any high risk cytogenetic abnormality and who are MRD negative after transplant at 10 power minus 6, and then they would be randomizing them to doing nothing, just active surveillance versus whatever the standard of care maintenance at that time would be, which can either be Len or DARA-Len based on, when the trial opens. If a patient is standard risk and they're MRD positive after transplant, I use single agent Len, but I do discuss the data on DARA-Len as well in these patients. And on a case by case basis, I do add DARA to Len if they're MRD positive. Now, if they have one high-risk cytogenetic abnormality, again, similar, I do single-agent Len, but I do add DARA if they're MRD positive post-transplant on a case-by-case basis. And in patients who are double hit, triple hit, or really high-risk patients, in those patients, I usually take a much more aggressive approach as long as they are fit. So I typically do, the induction transplant, and then I would do additional consolidation with about 4 additional cycles of either DARA-VRD or DARA-KRD. And then I do a PI plus Len maintenance indefinitely. And I tend to choose KR more than VR, given the randomized data is with KR, but VR is totally reasonable as well. And the only thing I would not use is Ixazomib plus Len. And the goal here would be to achieve a sustained MRD negativity at 10 power minus 6. And here, this is the population where we really need novel strategies like T-cell engagers. Now, I just wanted to put in this, that certain maintenance trials, that give me a heart attack. So this is one of the maintenance trials that is, thankfully, I think it's closed now, but it was running in Australia for some time, and I don't think it could accrue, where they were randomizing patients to selinexor and Len versus Len. Now, there are some drugs which I don't think they belong to maintenance treatment. I would put selinexor in that category because selinexor does have a modest single agent activity, but it has such high toxicity, including nausea, vomiting. It's not a drug that patients can keep taking for 2-3 years, in the maintenance treatment. I think they could not accrue because of that. And from the last update, I heard that it's either closing or about to be closed. So I don't think we will have the readout of that trial. Of the complete trial. There may be an interim report. Another drug that I would put in this category is belantamab mafodotin or Blenrep, which is again an active drug, has a single agent activity of 60% or so. However, it causes ocular toxicity, and I don't think we can expect patients to take that drug for maintenance when they're otherwise feeling well, to be on that drug for 3 or 4 months. 3 or 4 years, or for multi-year treatment with that kind of a drug. Then Majestic 4 is another trial, which is, using a very good drug, teclistamab, which is, as we all know, a very active drug. But I think it's a missed opportunity for risk-adapted maintenance, because, I don't think everybody needs just an aggressive approach for maintenance treatment. So here they will be randomizing patients to len versus teclistamab plus len versus teclistamab monotherapy. But my question is that should standard risk patients who are MRD negative post-transplant, who we know based on master trial and also the MRD2 stop trial by Ben Durban, that they have really good outcomes. Should they really accept the risk of severe infections or infection-related deaths with teclistamab? If this was my patient, I would not feel comfortable randomizing a patient like that to something like teclistamab, where they will need IVIG and they will need PJP prophylaxis, and maybe they get admitted a few times with pneumonia. I think we might be harming those patients. On the other hand, if we have a double hit patient who is MRD positive, of course, I would love to enroll that kind of patient. But unfortunately, this is a trial for all comers. It's not a trial only for high risk, and there is a missed opportunity here for risk-adapted maintenance strategy. One of the trials which I love is the SWOG 1803 dramatic study, where they basically at 2 years after Daralan versus Len, they are doing MRD testing. And at that point, based on MRD, they're further randomizing patients. So if patients are MRD negative, they are being randomized to, completely stopping versus Daralan. And if they're MRD positive, then also they are, being sorry, I'm sorry. If they're MRD negative, then they are being randomized to either stopping the treatment completely or continuing len. And if they're MRD positive, then they are being randomized to continuing len versus continuing daralan. And the primary endpoint of this is overall survival. So I think these are the kind of risk-adapted trials that we really need more and more, given that one size fits all is going to be very, very difficult with the current treatment paradigm that we have. So I just wanted to go back to the case that with our case, just to quick recap, it was an IgG lambda multiple myeloma with FISH showing hyperdiploidy and gain 1Q, RIS stage 2. Patient had a really good response with Dara-VRd followed by transplant, was MRD negative by Euroflow, was PET-CT negative. And, even though so you can argue that she does have one high risk abnormality, was gain 1Q, which is a little bit debatable when you have gained 1Q alone. Is that truly a high risk? We started her on single agent len maintenance at 15 milligram. However, she had very difficulty tolerating, with diarrhea, fatigue, requiring dose reduction to 10 milligram, then 5 milligram. And then at 1 year post-transplant, I repeated her bone marrow biopsy, which was still MRD negative 10 power minus 6, both on Euroflow and also on adaptive. And at that point, based on the data that we have from master trial, the MRD2 stop trial, I had a long discussion with her, and we made a shared decision to stop len completely and continue active surveillance. The patient is now 2 years out from stopping, enjoys excellent quality of life. And if and when she relapses, as you all know, there are a lot of options that we can use at that time. So with that, I'll stop, and I'm happy to take any questions. And I'll put in a plug for our podcast, Blood Cancer Talks, where we, discuss several topics in hematology. And I would encourage you guys to listen to it. With that, I'll stop, and happy to take any questions.
Thank you, Dr. Rajshekhar. That was an excellent talk, very well structured and thought through. You have actually covered the topic very well and presented the data, both the recent as well as the gold standard data based on which most of us use lenalidomide maintenance. Thoroughly enjoyed the talk and great listening to you. We have collated a few questions from our Indian colleagues. So I think first, a very basic fundamental question. What actually constitutes maintenance, especially when it comes to a relapse patient? Because very often in relapse patient, the paradigm is to give treatment till progression. But practically after 4 to 6 cycles or 6 or 8 cycles, patients very often, due to financial toxicity and otherwise, don't want to continue treatment. So how do you put these patients on maintenance in a relapse setting?
Yeah, no, that's a very good question. And I think, in the relapse setting, when we use the term maintenance, we mostly use it for newly diagnosed setting. We don't use for relapse setting. And in the relapse setting in myeloma, as you know, all the trials, they treat until progression. And as you said, for financial toxicity and sometimes also for time toxicity, like even in the US, if the insurance is completely paying for the drug, despite that, most patients after 6 months, 12 months, they just need a break. They just want to get back to their life. If they are on, let's say, Daracar carfilzomib dex, they don't want to come in like 3 times a month for IV infusion for 4 or 5 years. The PFS could very well be 4 or 5 years, right, with those regimens. So yeah, it's, I think I usually don't call it as maintenance. I just call it as continuous treatment, and I, discuss with the patients in that way. What I think is that as our treatments get better and better, as we have CAR T cell therapy, bispecific antibodies, in the relapse setting, we will hopefully start, going away from this paradigm of continuous treatment into a fixed duration treatment. I mean, with CAR T, we already have, for example, in the US, cilta-cel now approved for first relapse. So we are using, not in everybody, but we are using in a fair number of patients. So I have a lot of patients now who got cilta-cel, they're MRD negative, and now they're completely off treatment, and they maybe for IVIG for 5 6 months, and then they come off of IVIG, and then after that, they're only seeing me every 2 months. They're not coming to the chemo center at all. With bispecifics, I think the problem is the companies are again doing the same thing, like treatment until progression. But we are seeing that it's not feasible to do, if we do treatment until progression, almost everybody will have a severe infection, and many patients unfortunately died of infection. So, I think once the trials come out, we will see how the data looks like. But definitely a fixed duration bispecific trials, needs to be done, which are currently being designed.
And next question also, again, a very interesting one. In transplant ineligible patients, there is no uniformity regarding when to start maintenance. 6 cycles, 8 cycles, some of them give 10 to 12 cycles. So is there any data in this regard of when to start maintenance in a transplant ineligible patient? And does MRD make a difference if the patient is MRD negative versus positive at, let's say, 8 cycles? Does that influence your treatment decision?
Yeah, so regarding the data, we usually follow how the trials were designed. So if you look at all the transplant ineligible trials like IMROS or Cepheus, the induction was continued between around 6 to 8 cycles, where the cycle length in IMROS was slightly different. So in our clinical practice in the US, in transplant ineligible or in transplant deferred patients, we always do 8 cycles of induction. And at that point, we usually transition to maintenance at that point after 8 cycles. That's not based on any randomized data. That's just based on how the trials were designed. And regarding maintenance, so regarding MRD, so we typically, I mean, I usually follow MRD very, very closely only for ultra high risk patients, like the double hit, triple hit. For standard risk patients, let's say 8 cycles, if they're MRD positive, I would still go to maintenance with let's say if they got DARA VRD, for 8 cycles. If they are a fit transplant ineligible, let's say like a 65-year-old transplant deferred, then I would go on to DARA R and drop the Velcade after 8 cycles. Even if they're MRD positive, I wouldn't have any problem with that. But if they're double hit and I'm really worried, then of course, then I would just keep them on all of them and maybe just drop the steroid and maybe just lower the LEN dose a little bit to make it more tolerable, but just keep them on all 3 drugs.
So in your practice, if a patient is double hit or ultra high risk, there is no real concept of a maintenance. It's probably continuing the treatment with maybe taking off the steroids and bit of modifications in a transplant eligible setting.
In transplant eligible setting, yeah. So because the best data that we have for double hit, I would say, is from the Optimum trial of Martin Kaiser from the UK. Now that's a lot of treatment. I think they have like DARA VRCD, that transplant, and then so I don't do that intensive. But if you look at that data, I mean, with that kind of approach, the double hit patients, I think, had really good outcomes at the end of the day. So I have, for example, a 45-year-old who works full time and he's a double hit patient. And with him, I'm doing a similar approach like that because he's tolerating the drugs very well. He continues to work full time. He just takes 1 day off a week when he comes for the chemo. And he just doesn't want to relapse. He just doesn't want to, he's very worried about relapse. So, I think it depends on, of course, that approach will not be applicable for somebody who is 65, even if they are fit, it would be too much for them. But if somebody is young, I usually do that kind of an approach. It's like a continuous treatment.
And on that same note, in patients whom we have given DARA maintenance, especially after the first 8-9 months, we see them coming back with a lot of infections. I don't know if that is peculiar to our setting. Very often, post-transplant, 5 months, 6 months, we are not able to continue DARA, not because of a tolerability, but because of recurrent infections. Do you face such an issue in your practice? And the second question is, in such patients, just like what we do for teclistamab, giving monthly IVIG to reduce the infection risk. Do you think a similar approach may help if patient really requires DARA as a maintenance?
So, with DARA, our experience with infection has not been so bad. With teclistamab, it has been. We have had several deaths from infection. But with DARA, I mean, we do have patients who have infection, like pneumonia, but overall, it has been, I would say, fairly similar to the clinical trials. It hasn't been so bad. And yes, I do use, IVIG, but with DARA, we rarely see really profound hypogammaglobulinemia. Maybe the IgG level is 400 or 300, but not like bispecifics where it's double digits sometime. So
Yeah.
we rarely see profound hypogammaglobulinemia. But I would say the patients I would say who are on DARA and we see a high risk of infection are the patients who have another reason to have high risk of infection. Like, for example, if they have nephrotic syndrome for some other reason and they're also losing, protein from that and that made them seriously hypogammaglobulinemic, or they have other comorbidities like uncontrolled diabetes. Those are the patients in whom we see more infection. But with the fit patients, we don't see that much infections with DARA maintenance.
So our experience has been slightly different. When we have
Hmm.
DARA, even in the induction treatment, especially last 1.5 years, we have been using quadruplet for all our patients. We have seen when we take these patients for our transplant, the peri-transplant infection rate has also been significantly higher if they have received DARA. And the same
Uh,
applies to a post-transplant consolidation and maintenance. So we have been trying to put our data together and write this up, but this is something which we have faced in our practice.
yeah. Have you seen like even deaths from infection or mostly like serious infection?
Mostly serious infections.
Serious infection, yeah.
Mostly, we have not lost any patient, thankfully, but serious infections prolonging the hospital stay. The hospital stay in these patients undergoing transplant post DARA has been significantly higher than, let's say, the normal transplants after VRD.
Okay, okay. That's interesting. Yeah, I mean, yeah, especially if the infection risk is higher, the question is that whether that is worth it for the benefit that DARA provides long term, for the PFS and overall survival. That's the question. And I think, yeah, and that's, because the DARA VRD initial trials did not they did not have much representation from places like India, right? It was mostly in the US and Europe. And, that's why I think these trials need to have sites across the globe to get good idea as to how the safety profile is in different places.
And in high-risk patients, especially with more than two cytogenetic abnormalities, you mentioned giving a doublet maintenance with carfilzomib and lenalidomide. In practice, again, we find it very difficult to administer carfilzomib because it's an intravenous infusion. Patient has to come into the daycare. So
Yeah.
do you think for such patients, the standard practice of using bortezomib with len would also work equally well, considering they can take it at a local hospital or sometimes even a home-based administration is easily possible with bortezomib?
Yeah, so I think, it probably will, but the only thing that I think is that there is no randomized data, VR versus R, right? Now there is an older trial of Velcade plus thalidomide versus thalidomide from Spain. That was, I think, more than 15 years ago. That was a positive trial. So it does show that when you add Velcade to an IMiD, it does improve PFS compared to IMiD alone, unlike Ixazomib, where it was clearly negative. So so I think it's reasonable to extrapolate the data to Velcade. In the US, we cannot do Velcade at home. It's not allowed. So for us, for the patients, it doesn't matter. They have to come in anyway. So, and then typically in the maintenance, I will do Kyprolis every 2 weeks, not like 3 weeks on, 1 week off. And the Velcade is also every 2 weeks. So for me, it doesn't really, as long as they're tolerating the Kyprolis, okay, it doesn't really matter to me as much whether they're getting Velcade or Kyprolis. But yeah, that's why I tend to do KR more because of the robust data that we have from the randomized trial. But VR is okay too. It's totally fine.
And what is the Kyprolis dose you use for maintenance? Is it the same 56 milligram per meter square, or do you use a flat 60 mg dose?
I usually, for maintenance, I usually use 36 milligram per meter square, slightly lower dose. 56 is sometimes too much. Yeah, so patients do not tolerate well. So I usually use 36 when it comes to maintenance.
And do you routinely screen these patients with an echocardiogram or an ECG for cardiac dysfunction, or only if they are symptomatic? Patients on Kyprolis maintenance.
Yeah, only if they're symptomatic. But typically, if I'm starting Kyprolis, I will usually do a baseline echo in these patients, especially if they're older. In younger patients, I sometimes don't do it, but in older patients, I usually do a baseline echo. And after that, only if they're symptomatic.
And in LEN maintenance, also, there's a lot of discussion regarding definite versus indefinite maintenance,
Yeah.
maintenance for 3 years, 5 years versus indefinite. So, what is your practice? Like, if the patient is tolerating the drug, would you prefer giving it indefinitely, or do you say 3 years, 5 years, this is good enough and we stop?
Yeah, so that is, I think, an area where, although we don't have randomized data yet, but we are seeing a lot of data, like indirect data from different trials, right? So first is the Benderman's MRD2 stop data that showed that if you are on LEN maintenance for 1 year, and then at that point, if you're MRD negative, and if you stop everything, your 3 year PFS is 85%. So that's pretty good, right? Then there was another trial from Spain, which I did not show in the slides, but it was the same trial with ixazomib Lendex versus Lendex, which was a negative trial. So in that trial, what they did was that after 3 years of maintenance, it could be either IRD or RD, they did MRD. And if they were MRD negative, again, they stopped everything. And if you stopped everything, their subsequent 4 year PFS from the time of stopping was around
Yes.
88 or 85%. So it was really good.
Fantastic.
So yeah, yeah. So what in my clinical practice, I usually try to keep everybody on LAN if they are on LAN for at least 2 years. And then at 2 years, I typically do an MRD testing in the bone marrow. And if they're MRD negative, I discuss the data with the patients that, because here most of the time, let's say insurance is covering completely. So patients do not have the financial toxicity in mind unless they are having to give significant copay, then they do. But otherwise, they don't. But then I discuss with them that the data, and then many patients will say that 88% is good enough for them. They're willing to take the chances because most of the time Revlimid is causing some fatigue in them, some diarrhea, right? So and they will go and they will stop it. And sometimes patients will. There are some patients who will worry that they don't even want the 10%. But I tell them that even if they are on Revlimid, that doesn't mean it's zero, right? It's not that they will still relapse at some point. But usually those two pieces of data I find very useful to discuss with patients. That after 1 or 2 years, I usually tell them after 2 years, if you're MRD negative and if you stop Revlimid, the chances that your myeloma will come back in the next 4 years is 10%. So very, very low. So after telling them the data, most patients are okay with stopping. Now, if they're MRD positive, that becomes challenging because if they're MRD positive, then we don't have any data that to tell us, whether first of all whether Revlimid is even helping if they're still MRD positive right after 2 years, and if you stop, then will their disease come back sooner? I don't know. So in those patients, I try to keep them on Revlimid if they're tolerating it, even if at a lower dose.
And this is applicable mainly to standard risk patients.
Yeah, mainly to standard risk. If they are high risk, now we are learning more and more now that if they only have one high risk, then those patients are behaving more and more like standard risk in the current era, right? I mean, we still need some long-term data, but from what we are seeing from the Griffin trial, master trial, is that if you have only one high risk abnormality, you're still doing very, very well. So when I say high risk, I usually mean the double hit. Now, with the new high risk definition that will come out, soon, I think Dr. Nikhil Munshi and others, they have already submitted the paper and it should be out soon. That will really be helpful because it will kind of, really give a good definition of high risk. So I think they're removing T414 as the only abnormality as high risk completely because those patients do really well these days. That gain 1Q alone is not considered a high risk unless it's along with something else. So I think that will be a really good definition for high risk once it comes out.
And speaking about cytogenetic abnormalities, like the T414 you mentioned, they usually respond quite well to bortezomib. So do you
Yes.
think cytogenetic abnormalities or a myeloma NGS or a gene expression profiling, would that really influence your decision? Let's say a patient has T414. Would you rather prefer to put them on a bortezomib maintenance versus a LEN maintenance?
No, no. So yes, they do well with bortezomib, but they are getting bortezomib in induction, right? So they already got it. And then for maintenance, we don't really have any data whether, continuing bortezomib is going to improve their outcome. And then the other thing is, there was a few years ago, there was a paper by Dr. Martin Kaiser from the UK in Blood, which you may have seen, where in UK, they had the really large trial of LEN maintenance versus placebo. And then they were able to do really nice subgroup analysis in that trial to look at which are the subgroups of patients who benefited the most from LEN maintenance. And they found the patients who benefited the most were the patients who had one high-risk cytogenetic abnormality like T414 or T1416. So, with that data, with patients who have only one abnormality, not double hit, but not standard risk either, those are the patients I tend to keep them on len maintenance, for as long as possible because they really showed that strong benefit. And those who were standard risk, like hyperdiploidy or T1114, they did really well no matter what, even if they did not get maintenance. And those who were double hit, they did really poorly no matter what. But those people in the middle, they were the one who drove, I would say, 90% of the benefit that we saw in the overall cohort. So I don't necessarily do bortezomib maintenance in T414. I would do just len maintenance.
And in this specific group of patients that you mentioned with a single high-risk cytogenetic abnormality who tend to really benefit from maintenance, due to some reason, if they are len intolerant, would you consider switching them to a once in 15 days bortezomib versus stopping lenalidomide or reducing the dose? Let's say 10 milligram of lenalidomide, if they are still intolerant, do you think bortezomib would be an option for these patients?
Yeah, I mean, if they're intolerant, then yes, bortezomib would be an option. Or if they did not get DARA in induction, let's say if they got VRD induction, then I would even consider DARA because we know that if you get triplet induction, DARA maintenance really improves outcome, right, across all subgroups.
Yes.
So, yeah, if they can afford it and if they did not get, then I would even do DARA. If not, then bortezomib. My first consideration would be DARA, given the randomized trial is stronger with DARA. But bortezomib will be reasonable as well.
Again, a question, any role of steroids in maintenance?
I don't think so. So there was again an Italian randomized trial. I don't know the name of the trial, but it was by Francesca Guy et al., where they did this randomization of lenalidomide plus prednisone versus lenalidomide alone, and there was no benefit of prednisone, adding prednisone. So we extrapolate the data to say that steroids really doesn't really add much in maintenance setting. Yeah, it was a very large trial. It was published in Lancet Oncology, I think, in mid 2015 or something like that.
Again, few questions on maintenance in specific clinical scenarios. I'll just collate it. Maintenance in chronic kidney disease, patients with concomitant amyloidosis, with a heart failure, with a hepatic dysfunction. What would be your choice of maintenance in these three? End-stage CKD, post-transplant, heart failure with amyloidosis, and hepatic dysfunction.
So end-stage CKD, like on dialysis. So if they're on dialysis, I think we can still do lenalidomide. There is data. There was a phase 2 data showing that len can still be done in patients on dialysis. At a lower dose, of course. I would do no more than 10 milligram in those patients. And what was the second one? For hepatic disease, right?
Yes.
For hepatic disease, again, we can do len. Len should be okay to do as long as they can tolerate it. And DARA, of course, we can do as well. In patients who are on dialysis, like if, let's say, some of them, they cannot tolerate len, and in those situations, I have done daratumumab in some of those patients, especially if they did not get DARA in induction, because many of those patients got induction like 4 or 5 years ago, and they did not get DARA. And what was the last one?
And the third one is concomitant amyloidosis with heart failure.
Okay, so with amyloidosis, I think it's a little bit tricky because they don't tolerate IMiDs very well. So if they have myeloma and amyloidosis, from the get-go, I treat more like amyloidosis. So I would give them DARA VCD. I typically will not give them DARA VRD. And then if they're transplant eligible, I would do transplant. But as you know, most amyloidosis patients are not transplant eligible. So in that case, I would just follow the amyloidosis paradigm of DARA VCD followed by DARA maintenance. And then down the line, if they relapse, I would, if they are, most of the time they're not CAR T candidates, I really like to get bispecifics as early as possible for those patients because we are seeing that with off-label use with bispecifics are fairly well tolerated in amyloidosis, even in patients with advanced heart failure, because the risk of CRS with bispecifics is very low compared to with CAR T, right? So the chances that they are going to be having a significant CRS event is fairly low. But yeah, it's kind of tough. I would not use IMiDs in patients with amyloidosis, unless like I've exhausted all other options and that's the only option left, then yes, a low dose. They tend to tolerate POM better than len, so I tend to use POM 2 milligram more than len in those patients.
Again, very interesting question. Patients on maintenance with a biochemical relapse, would you escalate the maintenance? Would you add on something or just continue lenalidomide?
Yeah, so biochemical relapse, it depends. So, I don't act on all biochemical relapses. If it's a very, very slow relapse, patient is completely asymptomatic, and, I would definitely do a PET-CT or a whole body MRI to make sure that there is no new lytic lesions or something like that. Then sometimes I just watch them. I don't increase the dose of Revlimid or anything like that. Just continue the same and watch them. But of course, if it's a double hit patient, then I would definitely act on it. Then I would just switch treatment. I would not do anything with increasing the dose or something. Or if it's a patient which is with a rapid biochemical relapse, a doubling of the light chains every 2 months or every month, in that case also I would just switch it. So I tend to not. I know there was a practice before of just adding steroid or just increasing the length from 10 to 25. But given the options that we have right now, I usually don't do that anymore. I just switch to another treatment if I have to. But if it's an indolent relapse, then I just watch them at the same dose. And I mean, there are many patients, as you know, who don't need another treatment for many years, after the biochemical relapse.
Any role of other drugs like pomalidomide, cyclophosphamide in a maintenance setting? Is there any data for that?
There is no data, unfortunately, for those. Yeah, we do. Sometime I have seen that in patients who are on LEN maintenance and they cannot tolerate it, I switch to pomalidomide 2 or 3 milligram and they tolerate it well. There is no randomized data, but probably it is also effective given that LEN is effective. But there is no randomized data on cyclophosphamide or POM.
And coming to a couple of last questions. In patients on lenalidomide for a prolonged period of time with cytopenias, what is your threshold for doing a bone marrow to look for clonal evolution to MDS?
Yeah, so if they have cytopenia, so I typically would first decrease the dose of LAN and see if that takes care of it. Most of the time it does. And then I will not do a bone marrow. But if I have decreased from 15 to 10, from 10 to 5, and despite that they're cytopenic, then I would definitely do a bone marrow at that point to rule out any clonal evolution. And we typically also do a myeloid NGS panel as well.
And this question is probably pertinent for the Indian setting. Teclistamab is approved in India, and we have been using it for quite a few patients. And the results have been phenomenal. Even patients with plasma cell leukemia, a couple of them went into a CR with an MRD negative status. So my question is, because of significant financial toxicity, continuing them indefinitely may not be an option.
Yeah.
So at 6 months to 1 year, if they are in an MRD negative state, what would you really suggest? Like, if we cannot continue teclistamab, should we just observe them? Or do you think there is any role for LEN maintenance in this setting?
So maintenance, we don't know. We don't have any data of LEN maintenance after teclistamab. But regarding the question that you asked, that I think it's a very important question. And even in US, so I'll just tell you, for example, just like 2 weeks ago, we unfortunately had a patient die in our hospital. She was on a different BCMA bispecific antibody, the Regeneron one, on a clinical trial that she started about 1.5 years ago. And she was MRD negative CR. She was bone marrow done, MRD negative -6. Just like 2-3 weeks ago, she had a pneumonia at home. We gave her antibiotic. She started she started taking it. She was fine. Suddenly she got worse. She came to our emergency room. She was in septic shock. Started on IV antibiotics. Within 3 hours, she died. So this tells you that how the risk of infection is so bad with teclistamab. So definitely in patients who are MRD negative at 6 months or 9 months, there is a trial currently ongoing in the US called as Limitech trial, where we are stopping the treatment and then watching them. So far we have, there will be some preliminary data of that being presented at this ASH, but so far we have not really seen we have seen some relapses, but not a lot of relapses with the limited follow-up that we have. We looked at the data, in the Medical College of Wisconsin recently. The paper is currently is under preparation, where we looked at all the patients who were in clinical trials and they had to stop teclistamab for some reason, like infection or something, but did not die from it. They survived. And then how did they do long term? And many of those patients were on a low dose, with trial, lower dose of teclistamab than what is approved now. And we find that those who stopped teclistamab at 3 years, still 60 to 70% of patients, about 60% of patients at 3 years still remain alive and progression free. That's a high number, So those patients for 3 years, they're not on any treatment and they're progression free. So I think we need long-term follow-up data, but at this point, if you think a patient is at a high risk of infection, if they're MRD negative at 6 months, Yeah, absolutely. I think it's reasonable to stop it and just watch them. And I have done that in quite a few patients, especially elderly patients with whom I worry that they may die if they have a bad infection.
A couple of questions have come up in the chat box. Dr. Sham has a question. If you don't have access to NGS MRD or NGF next generation flow with a high sensitivity, how do you decide about the duration of LEN maintenance? I think that's a very pertinent thing when we discuss about stopping treatment, and access to an MRD with at least 10 to the power 5 or more is a must. So in a setting where we don't have a 10 to the power 6 MRD or even higher like MRD2 stop, they looked at 10 to the power minus 7.
Minus
But
7, yeah.
yes, if such a deep MRD sequencing is not available, what do you do? Would you still continue LEN indefinitely?
So yeah, that's good question. I mean, so if the MRD is not available, then I would probably go by the patient's risk status. So if the patient is standard risk, I would still be okay to stop Revlimid as long as they have received for at least 2 years. Because most of the randomized trials of Revlimid, they had 2 year duration, right? Except one or two which were indefinite. So as long as they have received 2 years, I would be okay stopping it. If they have one high risk or double hit or something, and the patient is only on LEN, in that case, probably I would continue for a little longer, so maybe 3 or 4 years. So in the UK, they did show that patients tend to benefit from lenalidomide maintenance for up to 4 years, but beyond 4 years, there was not much benefit. So in those situations, I would probably continue for 4 years. But if standard risk, I would still be okay, even without MRD stopping at 2 years, if the patient wants to stop and cannot afford it.
And a question from Dr. Krishna, how do you interpret PET-CT in the follow-up? I think probably what he meant is, do you do it routinely when there is biochemical relapse, and how do you act upon it?
Yeah, so no, we don't do routinely, only if there is a significant relapse and then we are concerned. So PET-CT sometimes can be difficult to interpret. So the main thing we are looking for when we are doing it is, are there new FDG avid lesions? Because then it's very clear that, we have to change treatment, right? But if there are no new FDG avid lesions, then, most of the time the report will say that the patient has multiple lytic lesions which are not FDG avid, or the SUV, is better than what it was at diagnosis. I think it's important to have that comparison for the radiologist to compare with what it was at diagnosis. So yeah, so that's how we basically interpret it, to compare it with what it was at diagnosis and if there are any new lesions. We are doing a trial at Columbia where we are looking at whole body MRI. For some reason, whole body MRI is actually cheaper in the US than PET-CT is. And we are actually seeing, our radiologists tell us that they find it much more helpful with whole body MRI to look at the ADC, and they can really tell whether a lesion is treated lesion versus it's really an active myeloma lesion. Whereas in PET-CT, sometime, even if there is a compression fracture, there's a lot of inflammation, it will light up a little bit, and it's not clear whether it's really myeloma or it's inflammation. Whereas with MRI, they can really tell based on the ADC whether it's an active lesion or treated lesion. So we are slowly transitioning at our center to whole body MRI instead of PET-CT.
And any added benefit of a CXCR4 PET scan?
I don't have any experience with that. We have not done it at our center, the CXCR for PET. Yeah, I don't know. I don't. Do you have availability? Do you have access to it at
So
your center?
it is accessible. I mean, as part of a small pilot study, we actually tried doing both for 5 to 10
Okay.
patients. There was one
Uh-huh.
particular patient where patient had a very small lesion in the liver, which was missed by the conventional PET, and it was picked up in a CR4. But I think we need to probably look at it in a lot more patients at different time points to see how best to utilize it.
Yeah. And do you have the whole body diffusion with MRI access to that at your
Yeah, we
center?
have all three. We have all
Okay.
three. And
Yeah.
like you rightly mentioned, very often, and especially in patients with smoldering myeloma, we have had quite a few patients who are PET negative or who had
Yeah.
ambiguous lesions on the PET, but we picked them up. We picked up the lytic lesions with a whole body MRI.
Whole
So
body MRI. Yes.
yes,
Yeah.
so at least in the subset of patients who are smoldering myeloma, there we really have a doubt whether to treat or to observe. We have actually shifted completely to whole body MRI. And surprisingly, even at our center, whole body MRI is slightly less expensive than PET scan. So
Yeah. Yeah. And also, I have had many patients in whom the diagnosis was upgraded from solitary. They came to us, referred to us as solitary plasmacytoma,
yeah,
based on a whole body CT or PET CT. And when we do a whole body MRI, one patient had 10 lesions, very small, but 10 active lesions. None of them lit up on PET scan. So the diagnosis got upgraded from solitary plasmacytoma to multiple myeloma in that case. So yeah, we have definitely for baseline, we have completely shifted to whole body MRI in those patients.
I think that's a very pertinent thing, especially in the Indian setting, where
Yeah.
availability of an MRI is probably still much more than the availability of a PET, especially in tier 2 and tier 3 cities. So if you have the right people looking at the MRI, probably it can be a very, very useful tool to pick up lytic lesions.
Yeah. The focal lesions, right? Yeah. And I
Yes.
mean the radiologists, as you said, have to be, even in the US, like we have only some radiologists who feel comfortable reading the myeloma MRI. Not everybody's comfortable with it. So yeah.
And with that, I think we have come to the end of questions in the chat box. And if there are no questions from anyone else, over the last hour and a half, it's been wonderful interacting with you. I mean, all
Thank
of
you.
us have a lot of doubts when it comes to starting maintenance, how long to give, what drugs, single drug, double, and role of DARA. And these are questions which patients ask us very often. Do I need to take these drugs lifelong? Can I stop at some point? I think your talk provided a lot of clarity on this, along with presenting the pertinent data on this. It was great listening from you regarding your practical experience and real life scenarios where you adjust maintenance in patients, especially those who don't tolerate the drugs. How do we navigate them? It was a very, very insightful discussion. And I thank you so much for delivering this wonderful lecture. I'm very sure everyone who has joined in, we have had total of 300 participants from 7 different countries joining in on various platforms, and everyone would have benefited from this talk. And this would go a long way in enhancing our practice as myeloma physicians. So on behalf of Fortis Institute of Blood Disorders and Delhi Hematology Group, I thank you once again for delivering this wonderful lecture.
Thank you very much. No, of course, yeah, and it was really a fun discussion as well for me.
And for all the hematologists and hemato-oncologists out here, I would really recommend listening to the podcast also, the Blood Cancer Talk. Very, very interesting podcast, again, covering pertinent clinical issues that we face in day-to-day practice.
Thank you.
Thank you, Dr. Rajshekhar.
All right. Thank you very much. Bye.
And before I wind up, I also thank MCure Pharmaceuticals for providing this platform to conduct this webinar over the last 1 year. And I thank one and all who have spared their time on a Friday evening and joined us for this webinar. Thank you, Anand.